So we often think of the placenta as just the baby's lung, right? The organ that supplies all the vital oxygen. But you know what? It has a secret identity. It's also a massive, powerful hormone factory. And understanding this is absolutely crucial for managing a pregnancy. So today, we're going to explore that secret life.
We all recognize this picture, don't we? You can see the fetal capillaries dipping into this pool of maternal blood, picking up oxygen and dropping off CO2. Now, this respiratory function is, of course, super important, but the main focus for us today is its other equally vital job, producing hormones. So here's our plan for today. First, we'll talk about a very important handover process called the luteal-placental shift. Then we'll get into the big hormones, progesterone, estrogen, and HCG, plus their supporters, HPL and relaxin. And finally, we'll see how all this knowledge about HCG is actually used in a clinical setting. It's going to be very high yield.
Okay, first up, the luteal-placental shift. Just think of it like a changing of the guard, a handover of responsibility from the ovary over to the placenta. Now, to understand this shift, we have to first remember the normal life of the corpus luteum in a non-pregnant cycle. So, after ovulation, around day 14, the corpus luteum forms, and it's completely dependent on LH to survive. It hits its peak performance around day 22, pumping out progesterone. But then, as the LH levels naturally fall, it's basically programmed to degenerate. Its life is meant to be very, very short.
So, this brings us to the most important question, right? If the corpus luteum is supposed to die off, how on earth do progesterone levels stay high enough to keep a new pregnancy going? What is the rescue mechanism here?
And the answer, my friends, is this hero hormone, HCG, or human chorionic gonadotrophin. As soon as that little blastocyst implants, its outer layer, the syncytial trophoblast, starts churning out HCG. Now, this HCG is very clever. It looks a lot like LH, so basically goes to the corpus luteum and says, hey, don't die, keep working, keep making that progesterone. It rescues the corpus luteum and keeps it going for about the first 10 weeks, which is just enough time for the placenta to get ready and take over the job completely.
And that whole rescue mission? It's all about making sure one hormone level stays high, progesterone. I mean, the name itself tells you everything. Progestation. It is for the pregnancy.
So look at the source. This is key. For the first 7 weeks, it's almost all coming from that HCG-rescued corpus luteum. The actual handover, the luteal-placental shift, happens somewhere between weeks 8 to 10. After week 10, you can be sure the placenta is fully in charge. And what is its main job? Well, it maintains the pregnancy by acting as a really powerful smooth muscle relaxant. It just keeps the uterus nice and quiet, preventing any unwanted contractions.
Okay, now let's switch gears and talk about estrogen. This is where a beautiful little partnership comes into play. You see, the placenta is very smart, but it has one limitation. It cannot make estrogen from scratch. It needs a partner.
So who is this partner? It's the fetus itself. The whole process starts in the fetal adrenal gland, which makes a precursor molecule called DHEA sulfate. This DHES then travels to the placenta. The placenta takes this raw material and, using its special enzymes, sulfatase and aromatase, it converts it into active estrogen. This entire beautiful system, this teamwork between the fetus and the placenta, has a name: the feto-placental unit.
And understanding this unit directly leads to a very high-yield clinical point for your exams. Listen carefully. In a condition like anencephaly, the fetal brain and, crucially, the adrenal glands are not properly developed. So if there is no fetal adrenal gland, there is no DHES. And if there's no DHES, the placenta has no raw material to make estrogen. So if you find very low maternal estrogen levels, it can be a big red flag for anencephaly.
All right, now let's quickly cover 2 other hormones that play important supporting roles in this whole story: human placental lactogen, or HPL, and relaxin.
The main goal of HPL is very simple. Make sure the baby gets enough sugar, enough glucose. And how does it do this? Well, you could say the baby gets a bit selfish here. HPL makes the mother's body more resistant to her own insulin. This means more glucose stays floating around in her blood, making it easily available for the fetus to grab. And this is exactly why we often call pregnancy a diabetogenic state. Next up, we have relaxin. And you know, the name really says it all. It relaxes things. It's produced by the placenta, the corpus luteum, and the decidua, and its main jobs are to relax smooth muscles, like in the uterus, and to cause vasodilation, which means it widens blood vessels. This vasodilation is super important because it increases blood flow to the mother's kidneys, which is why the GFR goes up during pregnancy.
Okay, everyone, now we are going to do a deep dive into HCG. This is not just the rescuer hormone we talked about, it is the master diagnostic marker of pregnancy, and I guarantee you this is extremely important for your exams, so please pay close attention.
Let's start with its structure. So HCG is a glycoprotein, and it has two parts, two subunits, an alpha subunit and a beta subunit. Now the alpha subunit, it's common. It's almost identical to the alpha subunits of other hormones like LH, FSH, and TSH. But the beta subunit? That is the special one. It is unique to HCG. And this is the whole point. This is why all our pregnancy tests, from the simple urine kit to the blood tests, are designed to detect the beta subunit. It ensures the test is specific and accurate.
Now just look at this curve. It tells a beautiful story. In a normal pregnancy, HCG levels just shoot up right after implantation. They rise rapidly, peak at a very high level, around 100,000, at about 10 weeks of gestation. After that, they gradually come down and then stay at a lower, stable level for the rest of the pregnancy. This specific pattern is the signature of a healthy pregnancy.
Now here is a golden number you must remember. 48 hours. In a healthy early pregnancy that is inside the uterus, the beta HCG level should roughly double every 48 hours. This doubling time is a key indicator that the pregnancy is viable and in the right place.
Okay, so that's all the theory, but how do we actually apply this knowledge of beta HCG in our day-to-day clinical practice? Let's walk through a very common scenario that you will definitely face. So imagine this. A patient comes to you, her urine pregnancy test is positive, but she is very early in her pregnancy, maybe less than 4 or 5 weeks. So you do an ultrasound, but you can't see anything inside the uterus. Now what? The answer, the standard protocol, is to order serial beta HCG levels. That means you take one blood sample today, and you tell her to come back in exactly 48 hours for a second one. Then you look at the change. So how do you interpret those results? It's actually quite straightforward. If the HCG value has increased by at least 66%, which is basically doubling, you can be very reassured. It's most likely a healthy, viable pregnancy that's growing inside the uterus. But if the value has a very poor rise, say less than 30%, or if it's actually falling, that is a big red flag. It points towards a non-viable pregnancy, like an impending abortion, or something more dangerous like an ectopic pregnancy.
And this table here, beta, this is extremely important for your MCQs. You need to know the conditions that cause abnormal HCG levels. So for very high levels, think of twins, a molar pregnancy, or gestational trophoblastic neoplasm. And very importantly, Down syndrome is also associated with high HCG. For decreased levels, as we just discussed, think of ectopic pregnancy or an abortion.
All right, that was a lot of information, so let's just do a very quick, rapid revision of the most important high-yield points that we discussed today. So, the key take-home message for you today is this. The placenta is not just a passive filter. It is a dynamic, powerful, and absolutely essential endocrine organ. Understanding its hormones, HCG, progesterone, estrogen, isn't just for exams. It's fundamental to managing a healthy pregnancy. Now, I'll leave you with a final thought to ponder. We saw that HCG levels are increased in Down syndrome. Why do you think that is? Try to connect it to the pathophysiology of the condition. Okay, thank you for watching, and I'll see you in the next one.